So hello everybody, and thank you very much for joining me this afternoon. Today, I think this is something we really look forward to. Martin Sitadi from Houston, and he's a very well-known, internationally renowned rhinologist, and he's going to talk to us about something that's very practical, very common, very daily, which is office procedures in rhinology. Martin, good morning to you.
Good afternoon. Thank you for the invite and the opportunity to share some of my thoughts about office-based procedures.
That's great to have you. Thank you again. Thank you for giving us the time. By the way, how was your session, the Frontiers in Otolaryngology?
Actually, it went really well. We went completely virtual. We didn't really know what to expect, but we had more than 100 participants, really from all over the world. It really worked out well.
Excellent, excellent. You know, the timing was not great for us because it ended up being like your afternoon is actually basically 10 o'clock at night for us.
Right. Yeah, it's true. You know, when we originally planned it, it purely was a local meeting. And obviously, we changed it because of the pandemic to virtual.
That's great. All right, Martin. So you have the podium. Please go ahead. Thank you.
Okay, let me start sharing my screen. I want to. Okay, let me go to. Can you guys see that?
We don't see anything yet.
Okay, sorry. Let me. Okay, it's not letting me go to full screen mode. Sorry about that. I usually use our institutional platform is WebEx.
Oh, okay.
So I'm going to have to.
You push on the
like
you push on the share screen, right?
Yeah, I'm trying to go to full.
Okay. Well, once you're on, yes. Okay. So, but are you sharing? But are you sharing? You have to share the window, the window, the PowerPoint window. It says share screen
Right.
share.
It's.
It says has started screen sharing, but we don't see anything.
Right. Hold on. How about now?
Okay. Perfect. Yes. Thank you.
You got it. Okay. Sorry about that.
No problem.
I'm going to present on office procedures in rhinology. This is a very practical talk about how to start doing office procedures, and if you've already started doing them, how you can add to what you already do. This has been a very hot area in the U.S., partially because of changing reimbursement, and also because there's a lot of new technology and new things that have been developed for us to use in the office. This is my disclosure. So first of all, I'd like to discuss the rationale for office procedures. Clearly, we're always interested in providing a lower cost setting for healthcare delivery. Healthcare really everywhere has gotten too expensive. We also need to conserve operating room resources, mostly for the same reason. So if we can move simpler cases out of the operating room, that's obviously attractive. From a patient perspective, patients like office procedures because it's less disruptive to them. From the surgeon standpoint, the logistics are very easy, and that's obviously a positive from our standpoint. In the U.S., reimbursement has been quite favorable, and that has driven part of this. But with all these dynamics going on, one of the things that I've struggled with is whether or not we're really adding value. Are we just expanding the indications for intervention and those interventions adding value? Are we really driving a migration from a high-cost OR to a lower-cost office setting, or just doing more procedures because we can? And this is a really difficult question. I'm not going to answer it directly, but it's something I think that we all need to keep in mind. So when I first started thinking about office procedures a few years ago, the way I conceived of it is sort of option A versus option B. And so option A would be more office oriented, option B would be more OR oriented. And in the office, it would be sort of the balloon procedures, maybe some navigation, maybe a partial exploit, but clearly less extensive types of interventions. And then the OR would be reserved for conventional endoscopic sinus surgery, where we do complete, go after all of the sinuses, use navigation, really do the maximal surgery. But as I began to think of that and examine that more thoroughly, anecdotally, it became apparent that there were certain indications or certain situations where the degree of improvement was much greater than the intervention. Those are just anecdotes. And when I looked at the literature, there are a few instances that begin to document this. And what I'm sharing here is a laryngoscope publication of a new, basically, device for opening the ethmoidal bulla. And it's basically a punch that opens the bulla. And what they showed in the CT scans is before in panel A versus panel B, there was an improvement in all the sinuses from doing a relatively minimal intervention. And the same thing is shown in this example from C to D. And they show that very clearly in table 1. So this shows, at least in this limited study, that a small intervention can have more of an impact than we normally would expect. The same thing is true in some of the other publications related to balloon sinuplasty. This is from an in-office, case series, basically, with 1-year follow-up. But they shared this CT scan. The top panel shows the pre-balloon sinuplasty CT, and the bottom one shows the post-balloon sinuplasty CT. And what I think you can see is a fairly dramatic improvement in opacification of all of the sinuses. Much more than the degree of intervention would suggest. This phenomenon is not that unusual. Pareto's principle basically says that 80% of the effects comes from 20% of the causes. This 80-20 rule applies to a lot of things in business, in medicine. It seems to be a very common principle. So what I talk about with patients now is the idea of achieving an 80% solution. And then the thing I have in the back of my mind, will a patient be satisfied with an 80% solution? And if I think their threshold for satisfaction is too high, then I'm more likely to recommend an operating room, more complete procedure. The other thing to keep in mind about this more nuanced approach is that if you do an office procedure, and the patient doesn't get the degree of improvement that's desired, there's a very easy salvage path. You always can go to the operating room and do a completion procedure or a more thorough operation. And this is something that I will discuss with all of these patients before doing an in-office procedure. Another important thing is to prepare the office for this. So there's a lot that goes into staff training, supplies, revenue cycle. I'm going to speak a lot about supplies and equipment, but I do not want to underplay the importance of having staff appropriately trained and also having the business office, the revenue cycle piece of this in place, because these are new things that are just goes beyond the standard ENT office. This is what we're going to touch on. Over the past week, I added an entire section on COVID-19. There's obviously a lot of concerns about maintaining safety in the office setting during the pandemic, and I want to share a few thoughts on that to start. So COVID-19. So early on in all this, basically in March, Patel et al. At Stanford launched a global debate in ENT community based upon anecdotes out of China. One of these anecdotes was about a transsphenoidal hypophysectomy procedure in which allegedly 14 patients became infected with 14 staff members became infected with COVID. And from that, she teased together anecdotes from all over the world, and that led to informal discussion on social media and via email, and then ultimately this publication in the Neurosurgery Journal. A few weeks later, Wang, who was, I think, the chief of neurosurgery at the hospital where that initial transsphenoidal case was performed, disputed some of the facts in Patel's initial report. My read on this is a lot of politics going on in China over who's responsible for what in regard to the COVID pandemic, but clearly as ENTs, we are in a unique situation of potentially greater exposure because we know that the SARS-CoV virus has a high resonance in the nasal tissues and the nasopharynx, and there are clearly risks associated with asymptomatic transmission. So patients who are infected with the virus can spread the virus even when they have essentially no symptoms. Another report that came out was this study from the New England Journal of Medicine that looked at the stability of the SARS-CoV-2 and CoV-1 viruses. So SARS-CoV-2 is similar to other coronaviruses. And this is important because any of these studies that compare SARS-CoV-2 to other things, it behaves similar to other coronaviruses and really similar to other respiratory tract viruses. So even though we don't know a lot about this particular virus, we can make some pretty good assumptions. So what this study highlighted, though, more importantly, is that the viability of the virus is pretty good for long periods of time. So you'll notice this looks at the titer of viable viruses in hours. And so on a copper surface, you can see it maintains a viable titer, for basically 8 hours, so long durations of time. And what this means is that if there is a surface that is contaminated with the virus, additional cleaning must be necessary. You just need to take additional precautions. But clearly, when this first came out, it caused a great degree of concern. A lot of our procedures generate aerosols. We never really thought about that, but we've been working in the face of aerosol generation for a long period of time. Aerosols are very complicated to model, but it's something that we need to recognize. So this is the first publication about aerosol generation during endonasal procedures, and what it shows in a cadaveric model is things like the drill and cautery generate a lot of particles per minute, while a suction doesn't, a microdebrider doesn't, standard instruments do not. So if you're doing procedures that involve drills and suctions and cautery, the exposure to office personnel, staff, and patients is pretty high. We've done a similar experimental setup. We actually used a cadaveric model in our ambulatory surgery center and did some comparisons looking at various devices: bipolar cautery, microdebrider, high-speed drill, coblation, radiofrequency ablation, and cryotherapy. And clearly, the drills in bipolar cautery generate the greatest amount of aerosol. This gets a little bit more complicated because you look at the size of the various particles, and there's a little bit of a debate about whether or not the smallest particles are relevant for disease transmission. But we do know that we can generate small particle aerosols, and this is what's driving the need for using N95 level of protection during procedures such as coblation or cryotherapy, certainly using the drill and cautery on any mucosalized surface. So we've taken several precautions. We are screening all of our patients, visitors, and staff every day. So you can't enter the office without being screened for symptoms and having a temperature check. Everyone is required to wear a face mask. We've introduced new measures for cleaning all surfaces. During any aerosol generating procedure, N95s and face masks need to be worn. We've also added powered room air filters to each of our exam rooms. Any endoscopy procedure is by definition an aerosol generating procedure. Anything that can induce cough or sneezing is also an aerosol generating procedure. Now, we've also added this category of high aerosol generating procedures, and this is defined by the surgeon. So if a surgeon has one of these and is doing something in the office, we require that the surgeon wear a gown, and the surgeon should consider COVID-19 testing in that patient as well, pre-procedure. Okay, another thing that I want to talk about is anesthesia. Whenever I give this presentation, there's a lot of discussion about the right techniques for anesthesia for office procedures. So in our office, we use oxymetazoline as our decongestant and lidocaine as our injectable and topical anesthetic, and we apply it. We used to use an atomizer, but because atomization can produce aerosol generation, we now just use nasal packing, both with oxymetazoline and lidocaine. We also will infiltrate selectively with 1% lidocaine, 1 to 100,000 epinephrine. In the U.S., we used to have tetracaine available for ENT preparations. That is no longer true. I'm not sure about the status in the rest of the world, but in the U.S., it's just available as an ophthalmic preparation, and it has to be if you're going to use it as an ophthalmic preparation, there are compounding pharmacies that will basically transform that to a nasal mucosal preparation. The regulation of compounding pharmacies in the U.S. is a little bit of a gray zone. There are some unscrupulous actors in this area. And so for practitioners in the U.S., I recommend caution, because technically a compounding pharmacy can only make a medication for a specific patient. They cannot do bulk compounding. Bulk compounding is regulated in a different way, but some of these smaller operations will kind of blur that distinction. And the places that are doing that are also blurring the requirements around safety and sterility and all the other things that you need to be wary of. So my recommendation is to use the official ENT preparation. And if you want to go down the compounding pharmacy route, you need to ensure that it's being done properly. You cannot assume that it's being done properly. The other thing about tetracaine versus lidocaine is the safety factors. So tetracaine is very potent and it has a slow onset. So if you use it, you have to give it a delay before you do anything else. But the maximal dose is very low. It's only 1.5 mg per kilogram versus 4.5 mg per kilogram, which means the maximum dose of tetracaine in a 70 kilogram person is only 105 milligrams. Some preparations of tetracaine are 7%. 7% tetracaine is 70 milligrams per milliliter, which means you only can use about 1.5 milliliters before you're hitting the maximal dose. And so you have to be really careful about keeping track of your total dosing of tetracaine. The other thing is if you combine tetracaine with other anesthetics like injectable lidocaine, the effects are additive, and it's a little bit harder to predict the maximal effective dose under that situation. But be really wary of tetracaine because it tends to be in very high concentrations and has a much lower threshold for toxicity. As far as the adverse effects of local anesthetics, most of them will produce some burning or stinging at the administration site. This is probably pH related, and that's what causes it. You really can't get around it. There are also the CNS and cardiovascular complications. So the CNS complications of all of the local anesthetics produces CNS stimulation. And what that means is people will start to get jittery and a little bit hyper and kind of feel anxious. And then they go abruptly into CNS depression, including respiratory arrest. Now, what is also important to remember is not every patient progresses through CNS stimulation to CNS depression. Some go right into the depression stage. The other issue is that epinephrine, if you use a topical or injectable epinephrine, that also may add to the CNS stimulatory effect. And then from a cardiovascular standpoint, the high plasma levels basically decrease cardiac transduction of signals, so they can go into bradycardias, arrhythmias, and ultimately hypotension and cardiovascular collapse. And then if you use anesthetics that have epinephrine, you have to worry about hypertension and tachycardia. And obviously, if you're using topical anesthetics and you anesthetize the pharynx, there's going to be suppression of the gag reflex. This is a brief video showing my anesthetic technique. Usually I use a lidocaine gel, not tetracaine, for the reasons I've explained. I'll put the gel in and you'll see it squirt out. One of the issues with the gel is it kind of looks like pus. Then we'll add pledget soaked with Afrin and lidocaine and set up NuCalm. I'll describe NuCalm in a bit. And then after a few minutes have elapsed, we go back in, we suction out the lidocaine gel. At this point, you can sort of manipulate things a little bit. I want to get better access to do a phenopalatine injection. So you see that I'm compressing the inferior turbinate and just lateralizing it just a bit so we can do a transnasal phenopalatine block. This is done with a 21 or 22 gauge spinal needle. And you get a good blanch the same way you would in the operating room. I think this is really important technique to master for the office setting. Gives you a lot of room to do procedures. Obviously, the risk is that you're going to bag a branch of the phenopalatine artery. You need to be ready for that. That has happened to me, and we were able to manage it because we were prepared. But if you're not prepared for managing a bleed from the phenopalatine branch here, it's going to be a problem. In Houston, there are 2 or 3 or maybe more offices that are actually giving basically general anesthesia in the office, offering IV sedation or full-blown total intravenous anesthesia. We're not doing that. I'm not sure it's worth the risk, to be honest with you, unless you have a full-blown anesthesia machine, a nurse anesthetist. There's a lot that goes into doing this safely. There are other ways to sort of facilitate office procedures. There's a lot of literature around acute procedural anxiety reduction in adults. And so this really makes any office procedure problematic for patients. And the anecdote around this is patients who fear going to the dentist. But that really applies to any medical or dental or surgical procedure. You can use medications to control this or cognitive behavioral therapy. Cognitive behavioral therapy is just a fancy way of saying is that you engage the patient through education, you explain to the patient what's going on, you give them some control over the situation, and you work to optimize patient comfort. If the patients have understanding about what's happening, what's going to happen next, you get more buy-in, they're going to tolerate more. From a medication standpoint, the typical things are diazepam and the other benzodiazepines. These need to be dosed 30 to 90 minutes before the procedure. Obviously, you have to be worried about sedation. And then there are some other options, including melatonin, gabapentin, metoprolol. We were using many of these. We really backed off as we improved our anesthetic technique. If you're going down this route, patients have to be counseled that they need somebody to drive them. There is also some discussion about using the gabapentinoids as basically the way to reduce post-operative pain. It's better understood there, not so much as for intraoperative pain relief, although they're used for the same reason. These medications have a longer onset to getting an active CSF levels that are necessary. And then there are some side effects of dizziness, sedation, and confusion. And so I think they can play a role. But if you're going down this route, you have to really read up on them, know what to expect before you start to employ them. Things that you can do that are easy are environmental measures. And so having a patient have an eye mask on during the procedure or sunglasses kind of decreases the visual stimulation, makes everything a lot more tolerable. Having the room quiet or even music in a quiet room is helpful. The other thing that we often do, or we do all the time now, is we hide the equipment. When we first started doing this, we were so proud of ourselves. We're all this fancy OR type equipment we had in the office. And when patients went in the room, you could see them tremble at the sight of it. So now we kind of keep everything in the back of the room, and it is covered with drapes, so patients are not really looking at all the instruments and needles and stuff like that. It just really facilitates the patient experience. We also use NuCalm, which is a non-pharmacological relaxation technology. The idea is that it induces a parasympathetic dominance, and I'll just explain what that is. So there are basically two main parts to NuCalm. The first is neuroacoustic software. So the patient wears headphones that plays music, and the idea behind the music is it's supposed to entrain the brainwave function and leads to this pre-sleep alphathetic state. So it makes patients relax. And the music is chosen such that the frequency and the tones of the music is such that it kind of facilitates the development of this state. This has been studied in the literature, but is not FDA cleared for this indication in the US. What is FDA cleared is the use of a cranial electrotherapy stimulation device. So we place electrodes on the patient's necks that basically deliver a very low voltage or current. This has been designed for the reduction of anxiety, depression, insomnia. And there's good literature around this and an FDA clearance. We use this because it helps patients feel more relaxed. And I've put it on, I've had my staff put it on. They volunteered to put it on, and it's very relaxing when you apply the cranial electrotherapy stimulation, particularly with the neuroacoustic software. So it makes patients relax. This is what it looks like. We've got all our navigation equipment set up, video tower, but these are the cranial electrical stimulation electrodes. These are the headphones playing the music. That's part of the NuCalm technology. And so we've looked at this from a patient standpoint. The acceptance is really quite high. Now I want to shift gears about preparations in terms of the types of equipment that you need to consider. So obviously, balloon sinus dilatations are very common office procedures. In the US, there are two platforms, Intellis and Acclarent. Each has its pros and cons. Personally, I think it depends on your target, which one you use. Although most surgeons just use one, I think it's better to choose the one relative to target. I also think there is a balloon company out of Germany, but I don't really have any experience with that one. You have to be ready for epistaxis management. And my thinking on this is resorbable materials are preferable. Cost is an issue, and for this reason, carboxymethylcellulose-based packing materials tend to be less expensive. We use blood stop, which is relatively inexpensive. It's well tolerated by the nasal cavity, but there are countless examples of things. But I do think you can be price sensitive and choose things that are less expensive and work just as effectively for a nosebleed. If you're going to use minimal meatal packing, carboxymethylcellulose is obviously a good choice. It's easy to inject something than put something in that's rigid. This is an example of it being injected. The carboxymethylcellulose minimal meatal dressings also tend to be less expensive. And you can mix them with both antibiotics and steroids if you want to do some drug delivery, although obviously they have not been formally studied or approved for that indication. Chitosan-based products are also very popular now in the US. So this is an example of Posicept. It has all the benefits of a chitosan-based polymer. And it is simply well tolerated. It's not super expensive either. The disadvantage is you can see when you put it in, it's sort of rigid like a wafer, and it can be a little bit uncomfortable to place even in an office setting. Other devices for use in the office are devices that combine irrigation and suction. There are two of these that are available. This is the Medtronic HydroCleanse, which incorporates irrigation that is sort of pump actuated with suction. And this is the Intellis Cyclone. Both of these are malleable, and so you can, pass it around a corner into the maxillary sinus or into the sphenoid sinus. And because they incorporate irrigation, you don't drown the patient with all this fluid running down the back of the throat. So it's much better tolerated. Another thing that is being done in the office now is balloon nasal airway remodeling. This goes under the term balloon septoplasty. I'm not sure it's a conventional septoplasty, but the idea is that you use basically an airway balloon. The Relieva tract is basically a tracheal stenosis balloon that's been rebranded. And you can use it to fracture septal deviations that, particularly a bony spur, does not work so much for the cartilage. You can use it for a hybrid septoplasty, so you fracture the spur and then make a directed incision to remove the bony spur. What this also does, though, is outfractures the inferior turbinates in a really minimally traumatic fashion. The first one of these that I did, and I was skeptical about this whole thing, let me add that. The first one of these I did was a patient who was on an LVAD on the heart transplant list and had to be on anticoagulants, but he was obsessed with his nasal breathing before his heart transplant, and he had a very bad septal spur. And we were able to do this in in the office in about 15 minutes. He tolerated it really well, and he had dramatic improvement in his nasal breathing. It also works in the operating room setting as well, and it's something to consider. It's not for every procedure. As far as reusable instrumentation, having the right size instruments is important. So they need to be small and delicate for use in the office. One of the craziest things that's made a huge difference is having an instrument tray that fits inside a tabletop autoclave system. And so this has been a huge help for us. There are also needles that will have a little stop on them, so you can't pass them more deeply. This is sort of like a designer version of a spinal needle for injecting the sphenopalatine region. Soft tissue shavers can be used in the office. One of the things that's a little bit of an active debate is whether they should be reusable or disposable as far as the tips. The advantage behind the reusable ones is obviously the cost per case is less if you do a sufficient number to capitalize the expense. But both options are available. The other thing you need to keep in mind with your soft tissue shaver is the amount of noise it makes. Some of them are much noisier. So the Karl Storz system tends to be more quiet than Medtronic. And also it has reusable tips. So if you want to go down that route, that would be an advantage for the Karl Storz system. Good video is important. And so we're always experimenting with different camera systems. Ideally, you have an operating room type camera tower. In reality, that is crazy expensive for an office setting, so we're often using other types of equipment, but it needs to be good equipment. And we also combine that with a video image archiving capability, so that's the screen that you see there. I mentioned epistaxis. The ability to control nosebleeds is important. You can get relatively small bipolar coagulators. There are also disposable, malleable bipolar suctions as well that you can get. And that also can be obviously helpful to have it available in case you need it. I am a big proponent of surgical navigation. I think it can play a role in the office setting because in the office setting, you need to be more efficient because the patient is awake. And so you have a greater need for precision. Transillumination is great for the maxillary and frontal sinuses, but you can't use it in the sphenoid. I also think there are false positives. For instance, if you have a large type 3 frontal cell or a supra-agra frontal cell, you can be in that cell and not in the frontal sinus proper, and it still will transilluminate. And so I think both the pathway and trajectory to your target are as important as getting to the target when you're doing balloon procedures in the office. There are now systems that are optimized for an office setting. So Theogon has a very small system, so their entire platform is a box on the shelf. It's not an independent tower. Medtronic Fusion Compact is also a very small system that basically the computer is in a all-in-one device with their EM platform, so plugged in, attached to the chair or on a separate pole, very low impact. There are also microsensors, and so microsensors can be passed via instruments or balloons. This is the Theagon wire. Acclarent TruDi navigation also is microsensor based. You can also navigate the Medtronic balloons with the NuVent system and their in-office navigation and really operating room navigation platforms as well. This is a picture of the Acclarent TruDi navigation. And so what I want to highlight is this. This is the EM field generator for the navigation. It's designed to attach to basically any ENT chair, and that gets it out of your way, which is an advantage. This is a video of TruDi navigation using a microsensor via for a balloon frontal sinus dilation. So with the microsensor, you can track the balloon into your target to confirm that you're truly in the frontal sinus, and you can see it'd be very easy to get hung up in this little remnant cell. But we're going to work around that, and then once we pass it, it'll be in, and then we can dilate it in the standard fashion. So TruDi is optimized both for in-office and standard operating room procedures. Now in the US, we've had some new technology introduced, basically designed for use in the office. This is the Clarifix device, which is now sold by Stryker. It's designed for basically cryotherapy of the sphenopalatine regions for patients with refractory rhinitis. This is a picture of the device, and the idea is in the office, you anesthetize the nose and you place the device here for a 30-second cryotherapy treatment. The data is really quite good. Patient symptoms start to improve within a week. And they get really seem to get a good long-term result, dramatic reduction in symptoms. I've done several dozen of these procedures, and these are among the happiest patients I've ever treated for something that is so incredibly simple. And this is simply an example. I've already anesthetized the nose. And the anesthesia is really important, and I'll discuss that in a second why. But here we are placing the cryoprobe in the sphenopalatine region. We want to basically apply the cold to the area where the sphenopalatine branches are coming out into the nasal cavity. The treatment is for a minimum of 30 seconds. You can extend that if you don't think you've got adequate, an effect on the tissue. Because of how the cryotherapy works, it does not cause a through and through burn on the tissue. So that's one of the advantages. After you finish the treatment, the tip is frozen. Patient has to breathe through the nose, and that releases it. And this is sort of what it looks like after. About a half of patients will develop a very thick exudate in that region, which is, it'll feel like they have a bad cold, and they may even report that they feel worse. That clears up on its own, or when they come back to the office a few days later, you can just suction that out, and it's just a thick gelatinous goop. The other thing is the reported rates of a post-procedural headache vary quite a bit. It's as high as 50 to 70% according to some surgeons. If a patient gets the headache, it lasts a couple hours and is relieved by over-the-counter medications, but it can be pretty bad. My headache rate seems to be less, maybe 20%. And the reason why I think it's less is I routinely do the sphenopalatine block, so I can prevent that headache from developing.
Yes. We're seeing a black rectangle. Is there a video there? Is there a video there?
No, the video ended. I'm just kind of describing the rest of the procedure.
Sorry about the interruption.
That's fine. Okay, so let me move on. Now, there's also two other new technologies sort of focus on nasal obstruction and rhinitis. There's Vivere, which is Aran Medical device, and Rynair, also from Aran Medical. This is a temperature-controlled radiofrequency ablation. Rhinair is for treatment of rhinitis. The treatment occurs in the same location as the Clarifix procedure. And then for nasal obstruction, Vivair can be done to the nasal valve region. I don't have videos to share this. It's newer, but it's gaining in popularity. One of the more interesting technologies is for the treatment of recurrent nasal polyps after prior ethmoidectomy. This is a Sinuva implant, which delivers 1,350 micrograms of mometasone over 90 days. It kind of looks like a spider when it opens up, so that's what it looks like. But the idea is that you anesthetize the inside of the nose, and then you can apply this for a patient who has recurrent polyps. It basically, wherever it sits, it tends to dissolve the polyps. It's a little bit bulky. It can be a little bit tricky to apply, but most patients do quite well with it. And it's a good alternative to keeping them on chronic prednisone or another trip to the operating room, or use of a biologic. And this simply shows the video of how it's deployed. And that's what it looks like. There are obviously concerns about crusting, so you have to, debride the cavity periodically without disturbing it. This is the table from their pivotal trial. There were two primary endpoints, the nasal obstruction score and polyp grade. And so they met both of those criteria. The polyp grade was much better in the treatment arm, and the degree of nasal congestion improvement was much better. And so it had other secondary outcomes as well. For the sake of time, this is a better way of looking at this. So there is a improvement in nasal obstruction and congestion as reported by an eDiary, basically a 30% relative improvement, and the polyp rate even had a 74% relative improvement. Now, what you have to remember, if you use this, it's wherever the thing sits is where the polyps dissolve away. So it doesn't clean the cavity completely, but it does reduce polyp burden, and the degree of improvement relative to the reduction in polyp burden is much greater. It's another manifestation of that 80-20 rule that I mentioned at the beginning. Now I just want to present a couple of cases. Now these are all office cases. I just want to do this to give a flavor of what some of the options are. So obviously this patient has a huge mucocele, as you can see on these CT scans. And the mucocele has quite a bit of orbital erosion. Now, certainly if a patient has a mucocele with orbital erosion and the mucocele is smaller, I probably would do it in the operating room. But this is such an enormous target that, I felt comfortable doing it in the office, and the patient was comfortable with an office procedure. And these are simply the CT scans. This is the video of the procedure. So we have a huge surgical target in terms of where we're going to enter. And I think I show the injection of the local. Yeah, so we basically are injecting directly into it. And as soon as we touch it, it begins to leak out the purulence. So we know, obviously, right away, we know we're in the right. Now, so we anesthetize the area, and then we used our small through-cutting forceps to enter it. We had to really push on it pretty hard. It had a pretty tough rind, as you can see there. But we're able to open it. Now, we didn't get an opening as probably as large as we would have in the operating room, but it was more than adequate. And so you can see we're sort of decompressing it. I want to get a better look in there, and then we're going to enlarge the opening even further. And then at the end, we'll actually pass the scope in. When you do these mucoceles, one of the concerns is they could have loculations or kind of demineralized bony walls in the middle of them. And so you have to be sure that the entire cavity is open. So after you open it, you have to create a relatively big opening and look in there and make sure that you've got the whole thing open. And so we're obviously enlarging it with the same instrument. And this is done all in the office, all in the local anesthesia, and we're just draining more and more of that purulence that probably had been in there for decades at this point. And we're able to get it all out. in an office procedure and create an opening that's going to be durable and long-lasting. So clearly, I think this is a good example of even doing something where there's a orbital erosion. Just like in the operating room, you don't want to leave any bony fragments at the edges. We also wanted to make sure that the maxillary sinus was open. I couldn't quite see the maxillary opening, so we worked on that a little bit to sort of clear up that area. And then the final thing we'll show is actually entering into the, using an angled scope. This is probably a 45, but then looking in and making sure that we could see all the way to the top of the mucocele into the frontal sinus. And you can see that as she moves her eye, there's a little bit of transmitted pulsations laterally. So that's a mucocele case. This is a patient who was a performer, a vocal performer. He basically, he was currently working as a singer on cruise ships. This is before COVID, obviously. And he was very reluctant to have traditional sinus surgery. This is his endoscopy. He had failed medical treatment with antibiotics, courses of both topical and oral steroids. He's got a lot of mucosal edema, septal deviation, middle turbinate is swollen. You can see a little bit of thicker mucus. That's the right side. This is the left side. Visualization on the left side is a little bit easier. You know, he was very reluctant to have a procedure done in the operating room because he was terrified of intubation affecting his vocal cords. And he heard that we did office procedures, and so he wanted us to do an office procedure for him. Okay, so this is his CT scan. So you can see his septal deviation. He sort of has this patchy inflammatory disease. It's more frontal than anywhere else. And so our main concern was getting the frontal sinus and secondarily the maxillary. But he was not going to be easy because of the degree of edema in his nasal cavity on the right side and that septal deviation. And then a little bit of posterior ethmoid disease as well. Okay, so this is a video. We anesthetized in the same way. He decongested pretty well, so we've got a decent view. And here we're passing our Acclarent balloon introduction catheter. And we're trying to sort of hook the back end of the Unstner process and start to pass the wire. And I remember when I was doing this, it was like really a struggle. I am showing the highlights and really edited this down. It was not this fast. But it was really difficult to get the wire to the point where we transilluminate the frontal sinus. But eventually we were able to get it and deploy the balloon in what seemed to be the right area. And so this is post-dilation. You can see we actually had achieved quite a bit. We got an opening there, and there's a potential for aeration on multiple spots. So we were pretty pleased with that. And then we did the same thing for the maxillary. And here, now, based upon where I am now, if I have a maxillary problem and it's like this, I probably would just do a standard maxillary enterostomy. We have all the equipment in the office. I think it's easier to do in most patients and allows you better ease of confirming you don't have recirculation or some other problem. But this simply shows that we did it via balloon-only technique, sort of in the classic balloon sinuplasty, methodology that was set out back, more than 10 years ago. So this procedure was done probably about 3 years ago. I last saw him about 4 or 5 months ago. He comes back periodically for a check, and he's doing well. He's just using some fluticasone nasal spray and is quite happy with the degree of improvement that he has. This is another patient who's got recurrent nasal polyps after prior surgery. You can see that there's scarring here and here. She's had some ethmoid work. The maxillary is open on the right side. On the left side, she's got some eosinophilic debris, a couple of polyps of different maturity. So she's not chock full of polyps. The polyps are relatively mature and cystic, and she's got some scarring leading to kind of obstruction of basically sinus drainage. This is her CT scan. So a fair amount of disease and sort of a bit of a difficult anatomic configuration, but she has relatively large sinuses, so there's a lot of space in which to work. Disease is worse on the left side, and she's got this sort of partition here that's going to be an issue, and then on this side, this narrowing here. And then further back, more bulky polyp disease. Anterior ethmoid artery is relatively exposed. So clearly, we're not going to be too aggressive up in the posterior part of the frontal recess. She was a very reasonable patient. She was not enthusiastic about undergoing general anesthesia. I explained to her that, what we could achieve, and she was willing to do an office procedure with the understanding that if we couldn't get a degree of symptom improvement that we wanted, she would need a regular surgery. So this is the procedure on the left side. So she's got these bulky cystic polyps, and part of it when I start is simply to decompress them to create some room. Now we're injecting some local. Video quality here is a little bit soft because we're using not a 1080p camera, so I apologize for that. So we've got the shaver. Sometimes I'll use actually the 2.9 millimeter inferior turbinate blade shaver for nasal polyps like this because they're relatively soft and it will take them down. And because the shaver is smaller, it's easier to manipulate in the nose. It works really well for that. And so we're just debulking polyps, kind of creating some room. And so she's awake, tolerating this well. And we're able to kind of remove all of the bulky polyps that we needed to kind of open up the middle meatus. One of my concerns in a patient like this is that when you remove a wall of polyps, there'll be a thick clump of eosinophilic mucus behind it. And so you have to be ready to remove that, irrigate it out, because if you leave that behind and you don't mobilize it, it's going to cause a problem for you at some point. It's just a matter of time. We also tried to address some of the bony restrictions. So here we are opening up that compartment that was on this side, and we're kind of gently opening that up. We're confirmed where we are relative to the orbit. We did have navigation set up for this case. I'm not going to show that, but she was set up to use navigation. But the goal was to open up that subcompartment that we saw on the CT scan, at least partially, so that area would have adequate drainage and presumably would lead to less recurrence of polyps. And then the other thing that we did for that subcompartment at the frontal sinus outflow, we elected to do a balloon sinuplasty. Now, typically you don't do a balloon sinuplasty during a polyp procedure, but we felt it was reasonable in this situation because it really was a bony restriction. And we just need to get aeration. And it seemed like an efficient way of doing that. So this is not so much for polyps, but just making sure that the frontal sinus is not stenosed. And so once we got the polyp out of the way, it was pretty easy to get the access we need to do sort of a conventional frontal sinus balloon sinuplasty, relatively atraumatic way of doing it. So I'll let this video play out. I think I show the final opening of it. So we're pulling it back, and then we're going to look. You can clearly see that we've got a much better view into the frontal sinus. It's not perfect, but again, I didn't want to take down more frontal sinus partitions posteriorly because that's going to be close to the anterior ethmoid artery, which was exposed. I mean, it's probably right here. So we had to do something that was less traumatic. Okay, so just to sum up, clearly office procedures have gained popularity in the U.S. over the past few years, but now there's almost been a pause on them because of safety concerns. I think the procedures can be done safely in the office so long as you do the right things with N95 protection and room air filtration, all the things I mentioned. Anesthesia techniques are obviously important. Surgeons need to understand the risks of the various techniques to avoid the toxicity. As far as equipment, you can do quite a bit in the office if you incrementally add on to sort of a standard ENT office, and a graduated approach is fine for that. You know, one of the things as a fellowship trained rhinologist that's been difficult for me to accept is that we don't have to have a perfect cavity to make patients feel a lot better. So less can be more. Office procedures are potentially cost saving, so that's clearly a positive. But also in the office setting, we have to be cognizant of the cost of all the supplies and equipment that we're using. From a patient perspective, the acceptance of these procedures is really very high. They do really well. It's less disruptive to their lives. And for quality of life disease, which is mostly what we're talking about, it's a huge win. And I think if properly applied, office procedures do give you durable outcomes as part of a comprehensive treatment strategy. I think we have a few minutes for questions. So if anybody has questions, I'd be happy to take them.
Thank you very much, Martin. Very, very interesting talk. I just have myself, like one or two questions. The first one is, over the last 5 or 10 years, do you see a trend in your practice pattern into more balloons or less balloons? Are you more inclined to use the balloons, or are you less inclined to use balloons? Like now versus...
I mean, my usage has probably been stable over the past few years. I probably use them a little bit more in the office. You know, I've never been a huge balloon fan, to be honest with you. I think they play a role, but I'm more inclined to use them in the office for very selected targets.
And the other question: would you attempt doing something with an intrachoanal polyp in the clinic?
I would consider it. I mean, it depends on the patient, depends how much room there is on that side. I mean, the challenge would be is you have to get the polyp out by the root of the maxillary sinus. And so you got to be able to look around the corner. And so you would have to have the angled scopes and the frontal sinus instruments. So I would consider it in the right patient.
And can I ask you to take a look? There's quite a few actually questions on the chat line. If you could scroll through the chat.
Okay, so I'll work backwards. So how do I remove fungus under local anesthesia in the office? Well, it depends on the degree of how much debris there is. Sometimes if the patient is really filled with debris, I will put them on steroids for a week and bring them back. And that gives you more room in which to work. It can be helpful to irrigate the sinuses. So you can just use irrigation through a suction, or if you have access to one of the dedicated suction irrigation devices, that's an option. The other thing to keep in mind is that patients who have allergic fungal sinusitis and have fungal debris, their sinuses tend to be expanded because of degree of polyp burden. So there tends to be a lot of room, and their noses are relatively anesthetic already. They don't feel pain the same way as someone who's got a type 1 inflammatory pattern. So you can do a lot more in debriding a patient with AFRS than you can a patient with CRS without nasal polyp. So you can do quite a bit. Okay, so the question before that is about older patients with CRS with nasal polyps. And so I think if an older patient has CRS with nasal polyps, they are good candidates for treatment. I do think they tend to do a little bit better, and that's because immunologically, they're not as robust as someone who's a teenager in their 20s. So they are less reactive upon re-exposure to the same antigens that led to the polyps potentially to begin with, or they just have less innate immunological activity, so they can do really well. But you need to, that rule is not 100%. The other thing too with older patients, I think, is that they tend to be more compliant with your post-surgical treatment options. So someone who's 50 and you tell them to do irrigations, or budesonide irrigations or something like that, they're more likely to do it than someone who's 25. I mean, that's just human nature. And so that the adherence to the post-operative treatment is also important. What type of sinus surgeries do I do under local anesthesia apart from balloon and cryo? So really the full gamut. I mean, we will do minor revision, endoscopic surgeries, kind of ethmoid work, maxillary enterostomy in the office. You can do inferior turbinate procedures in the office. I will present it to most patients as an option, and I'll tell them, you know, if they really want to avoid general anesthesia, this is a good solution. But like I said, there's a chance that we will not get the degree of improvement that they're looking for. And so it's sort of an initial step in patients who are interested in going in that direction. Some patients will come in expressly asking for it. And obviously we try to accommodate that request. But, you know, if they're not a good candidate for it because, you know, they're anxious, and you can pick out an anxious patient as soon as you walk in the room. You know, if they don't let you scope them, they are not going to be a good patient to do any kind of in-office procedure. If they're more calm and interested and they just have the right demeanor, that's going to be the right type of patient. All right, let's see. Okay, so as far as the cryotherapy, so the cryotherapy treatment is more for rhinitis than sinusitis. So these are patients who have excessive nasal congestion refractory to medical treatment or excessive postnasal drip. What we're presumably doing with the cryotherapy is inactivating basically the parasympathetic fibers to decrease the parasympathetic tone to the nasal cavity. So there's less of a signal to produce mucus. There is some good data that shows the depth of penetration of the cold. So it's not like taking a cautery and kind of burning through the mucosa of the bone. We're not really, you know, transecting nerves or vessels with the cryotherapy. And the notion behind cryotherapy isn't new. I mean, I think it goes back to at least the 60s. In articles in Laryngoscope, and it just fell out of favor because it was cumbersome. And then we had better, you know, quote unquote, better treatments for rhinitis with the introduction of topical nasal steroids in the mid and late 80s. Do I use ropivacaine for local anesthesia? No, I do. I only use lidocaine in the office. I think the duration of activity is adequate. I don't really need a long-lasting anesthesia, and then the safety profile is good. So I'm a lidocaine-only person in the office. Okay, next question. Talking about COVID effect, earlier advice included to prefer topical local anesthesia via packing rather than nasal spray. What is your advice regarding local anesthesia from office scopes to procedures in a sustainable manner in the rest of the pandemic? So, you know, as far as cleaning the instruments in the office, the coronaviruses, although they can last on a surface untouched for a long period of time, they are not very robust if you expose them to any kind of standard sterilization technique. So, for instance, we are looking at repurposing or reusing our N95 masks in the office as a cost-saving measure, but also because there's a shortage of PPE. And we believe, we haven't validated this completely, but we're close to it, is that using a standard tabletop CPAP disinfection device, which is a UV light system, will disinfect COVID and standard bacteria. So all the standard techniques are fine for repurposing scopes. You know, I know there's some of the companies have been promoting the idea of using a disposable scope because of COVID. I think that's crazy. The standard scopes, if you use the standard sterilization, will basically inactivate the coronavirus. What I would discourage, though, is using the eyepiece, because when you're using eyepiece, you are getting much closer to the patient than you need to. And if they cough or sneeze and they have the virus, they're going to expose you to it. And I think what really happens, what we have to worry about as ENTs in the office and awake patients, is minimizing coughing and sneezing and minimizing exposure to it. And so if you can stand a couple feet back or a foot and a half back versus being right in the patient's face because you use a camera, that's a huge, makes a huge difference. Okay. I think I've gotten all the questions. Oh, there are two new ones. Okay, so what do I do with patients with mucociliary disease in the pediatric group? I see my youngest patients tend to be early teenagers. I don't have a huge pediatric patient base. First of all, I think it's possible to scope patients in middle school and older if you coach them the right way. And so you can do endoscopy to guide your treatment. It's important that the patients will do their own treatment. So you can't have someone who is in middle school and have their parents irrigate their nose. It's not going to fly. So you have to get them to do their own treatment. But many times we use, essentially the same approaches we use with adults. If we have, if we think it's purely a mucociliary problem, we make sure the cavity is optimized. There's no mucociliary recirculation to maxillary sinus, for instance. We would use things like dilute baby shampoo. But the trick is that the kid has to do it to themselves rather than have the parents do it to them. It just won't fly.
Thank you very, very much. Really enjoyed your talk, and it was nice seeing you again. I think we're coming to the end of of our session. Again, I really appreciate you being with us this afternoon. And thank you guys for joining us, and hopefully we'll see you all tomorrow. Have a nice day. Nice.
Thank you. Have a great day. Appreciate the forum.
Right.